The topic presented today is you can beat opioid addiction. Here's how. And that's packaged and presented to me in a 3-part question. Let me read those 3 questions for you first, and then I'll sort of summarize it and get into it. The questions are, what is the first piece of advice that you give to someone struggling with opioid addiction? The second question is, what do I need to know before seeking help for opioid addiction? And the third question is, after admitting someone, how do you personally help them recover from opioid addiction? These are all great questions. They can sort of blend into each other. So let me just go ahead and start off with the general topic for today, which is you can beat opioid addiction. Here's how. And what is the first piece of advice that you give to someone struggling with opioid addiction? And with someone sitting in front of me here, first thing I always tell them is, and again, this is a little bit my clinical bias, and I have some authority over this topic, is please forget everything that you know about addiction and your thoughts on it. This is really important for me so I can start off with a clean, fresh slate so we can begin treatment. Oftentimes, people are sitting in front of me and they've been into 5, 10, 15, 30 different programs or have tried on their own for many years. And I believe a big part of this is there's a lot of misinformation and misalignment from social and individual perspectives on what addiction is and how to treat it. And I want to flush all of that out of their mind before we even get started. So I'm really clear. Forget everything you know and stop reading the internet. Number 2, I try to really educate them so they see addiction from the same perspective and a sort of paradigm that I look at it from, okay? And I really try to drive this issue home. I don't want to overwhelm them with too much information about what we're going to do. So if we're going to start talking about medication-assisted treatment, oftentimes the first question they pop up and ask me is, when do I get off of it? And I let them know. I said, I'm going to educate you about that, given whatever is out there about the science of things, but let's forget about that right now. Let's first of all make you understand that probably what you understand of addiction is wrong. Now, sometimes people get a little thrown off by this comment because they're like, well, I've been struggling with this for 5, 10, 15, 20 years. And number 2, they've been in so many programs. And if I see that sort of discontent under expression about the comment I made, I sort of follow it up with, if you've been struggling with a very difficult cancer for years, and the cancer has been cured or not, and you're in treatment, it certainly gives you a lot of expertise, insight, and validates a lot of thoughts and sort of anecdotal thoughts that you have about cancer treatment. But you're sitting on a very different side of this picture here. It doesn't make you an expert on cancer treatment. Even if you had a therapy that worked for you, that doesn't mean everyone should have it. And if you haven't had if you've had a therapy that failed, it doesn't give you a right to go around telling people, well, that doesn't work. In that same way, it sort of realigns the client or the patient when I say, please forget everything you know about treatment and what it is that your care the picture that your care needs to take. That's really important for me. So I oftentimes start off with that, and then I go ahead and start giving them some real numbers and data. The first piece of advice, and again, oftentimes I'm dealing with people that have had many failures, is that there is treatment and successful treatment for opiate addiction. You may have failed for a few reasons. 1, you didn't have the right treatment. 2, your perspective of what it is to get treatment and your expectations were not realistic. And here's what I mean by that, and I tell them, if you kind of approach this from a chronic disease model, okay, what does that mean? Well, and a harm reduction model. The chronic disease model, it sort of tells me that this is a relapsing, remitting issue, and you can have really bad relapses. And the word relapse, what I mean here is the whole weight of the disease coming down on you. What does it do to you physically, emotionally, and socially? The goal here is to get you to a place where you have almost no relapses and maybe none ever again. And when you do have a relapse, it's extremely minor and you can get right back on your feet. Let me explain this through an example. Let's say Joe comes in here and he tells me he had 6 months clean from heroin. And he's saying he was doing really well. He had a job. He had a girlfriend. He was out there working, paying his bills, doing really well. And he was counting the days because he sort of comes from that 12-step community where they really count the days, and that means a lot. And then there was one particular evening where he got into an argument with his girlfriend, or whatever that may have happened. Maybe his girlfriend left. And he gets into this argument, or the girlfriend left, or maybe he lost his job, or somebody stole something from his apartment. And that night, he goes out, and although he usually uses heroin, maybe he goes and takes a few Percocets. Maybe he does a line of cocaine. Maybe he does go ahead and do, shoots up some heroin. And what happens there, because he has a misunderstanding of what recovery is and what relapse is, he does that, and there's so much guilt because in his idea, I used, now I have to start from point one. Screw it. What does it matter? Who cares at this point? I destroyed my recovery. I had 180 days clean. Now I use, now I have to go. Now it's all gone. So this is sort of a negative feedback loop. And he's like, forget this. And he goes on this run and he loses everything. And then he does lose his apartment. And he does lose his job. And he does lose his girlfriend. Maybe he'll even lose his insurance. Or another scenario, which is almost just as bad, he goes ahead and uses one night, and then he has the same thought, and his understanding is, I, quote unquote, relapsed. Now I need to go into detox. Well, all of that is false, because let me answer the second one first, because you didn't relapse. You had an episode of use from a chronic disease. And so just because you had an episode of use doesn't mean you call the detox and go into detox and lose your apartment, lose your job, lose your girlfriend. You don't need a detox at that point. You do need rapid intervention. So you call whoever your caretaker is and say, look, I used last night. And they do whatever is needed at that moment for the degree of intensity needed to take care of the problem. And maybe that episode of use does turn into a relapse episode, which is much more intense and much more grave in its consequences to your health and your social circumstances. And at that point, maybe you need to go into detox. But the very idea that you had in your mind that I have relapsed and everything's thrown out the window and now I need to go to detox is destructive and itself can cause a true relapse. Or in the first case example that I used, the very idea that you think you used and all those days are thrown out the window and who cares now, screw it, I'm going to go on a 2-week run, that's extremely destructive. And that itself is causing the downward spiral. Whereas if you looked at this as like, I had an episode of use, all those days that I had healthy builds on the long-term momentum, both psychologically and really at the architectural and pharmacological level on your body. You've built synapses and tools to deal with a stressful situation, which is the use. If you looked at it that way, you wouldn't have the guilt, you wouldn't have the negative feedback cycle, and then you can actually potentially do the right thing and move forward in your continued recovery and evolution towards recovery. So the first thing I do is, let me kind of look at this again here and see what I wrote here. The first thing I do is, what is the first piece of advice that you give someone struggling with opioid addiction? It's really two pieces of advice. One, there is actually treatment and cure. And I don't want to use that word cure because it just it wraps the whole thing up into a sort of a definable paradigm, which I don't like. There's treatment and there can be a really good life. And if you want to call it cure, that's fine. But there is treatment. And number two, please forget everything you know about addiction, the way you look at it, the way you've been treated before. Now, that doesn't mean they got bad advice before, and it doesn't mean the treatment was wrong, but it's a good way to start, and I began that way. I also, at that same time, the other thing I let them know is one piece of advice I tell them, because when they come in, I make sure everyone knows you are not an addict. You are Joe who has a whole bunch of qualities as a human being, many, many, many of them positive, and some of them negative. Negative for you, negative for your lifestyle, negative for your health. So your name is Joe. Joe the carpenter, Joe the husband, Joe the brother, Joe the sister. So forget the idea that you're Joe the addict. You are Joe. And among a list of qualities that you have as a human being, one of them is that you struggle with this disease called addiction. And that's sort of the final piece of advice I give them. And then I sort of move into something else, which is the education part. So this leads into the second question, which is, what do I need to know before seeking help for opioid addiction? I think what you need to know is, what is opioid addiction, which I touched on a little bit just a couple minutes ago. You need to understand that this is a chronic relapsing remitting disease. So you need to really understand that concept. And it sort of begs the second question when you say disease, what is the treatment for this disease? And when you want to decide, well, which treatment should I seek? You need to make sure that the treatment you're seeking has scientific evidence behind it. And the treatment that does have scientific evidence behind it is medication-assisted treatment, in addition to all the psychosocial additions to that. Once you understand this, once you understand the potential for a relapse or reuse is the rule, not the exception, now you can start to choose and sort of shave off what kind of a treatment and what place you're looking for. So that's the critical thing that you need to know before you seek treatment. And also, I touched on this issue in question one. You also need to understand that this disease is something that you can beat because the data tells us you can beat it. So this, and those are the things you need to really understand before you seek out treatment. Otherwise, you're looking for kind of a losing battle and a declining cycle in your own physical health, in your relationships, but also in your pocketbook and the pocketbook of those around you. So keep all of those things in mind. And I'll go to the third question now. After admitting someone, how do you personally help them recover from opioid addiction? This also kind of stems from the first two questions. My own model, again, what I try to do is take all the science and data that's out there, blend it into my clinical experience and the clinical experience of those that know more than me, and gain their information and apply it to the individual. And for me, a lot of that is medication-assisted treatment. One other piece of this is the concept of harm reduction to the individual patient or client. And this is where it's a little bit vague and abstract. The concept of harm reduction is really a universal set of principles that put the patient in the middle, empower the patient, and allow the patient make decisions about their own care. And these are principles that are often applied to public health, public policy, or ideas that have to do with spread of disease. And, there's many ways to cut this. But for me, at the individual level, what this means is that I meet a patient where they're at in their recovery, how their worldview works, try to respect their limitations and their needs, and also their desires for how their recovery should look like. My job is to educate them, not ever judge them, and give them the tools for success within the sort of limitations and scope of what I feel comfortable clinically without endangering their life. Those are sort of vague, but let me give you some real life examples, okay? If someone's late for a clinic appointment, I don't charge them or I don't punish them by canceling the appointment. If someone has a dirty urine, right? The rapport I build with my patients and clients is certainly I don't charge them for that urine. I don't judge them or look down on them. And in fact, most of the time, they're going to get their medication. Now, there's obviously some rules and regulations that I implement simply to hold them accountable. But the key here is the idea of judgment and punishment goes out the door. And I try to be very empathetic and understanding to their situation because I'm the one that's saying this is a chronic disease. And I go from there. So, for example, if someone happens to be on Suboxone, let's say 8 milligrams twice a day, and they come in, let's say at this time, every 2 weeks, excuse me, they usually get to a place with me where they know that they can come in here and be honest. I almost don't need the urine. But if they come in twice in a row and their urine is positive for opiates or methamphetamines or whatever, they don't get charged more or they don't get kicked out of the clinic. This is something I have to keep at because I know the data shows me that applying it in this way, they will have a better chance of recovery. I just say, hey, John, we've done this for a month. You come in every 2 weeks and you got meth in there and you're supposed to be on Suboxone, but that doesn't mean you can do methamphetamines. So here's what we're going to do. We're going to change your care and you're going to come in once a week and you're going to give me a clean urine. And once you give me a clean urine, you can go back up to twice a week and eventually once every 4 weeks. That's one example of the idea of what I do a little bit differently, which is applying my interpretation of universal concepts of harm reduction to the individual care of patients. The other thing that I do and with my population of patients and clients is that I look at giving them medication-assisted treatment, in this case, buprenorphine, Suboxone products. I do it in a very different way than I think maybe some of my colleagues may. I don't limit the dose. I titrate it to effect, which is what the guidelines tell you. So it's not like, you can be only on 8 milligrams. You can be on as much as clinically appropriate and given my clinical interpretation of where you're at, as long as I meet my goals and you meet your goals, which is decreasing withdrawals and cravings. And there's a limit to that number, obviously. So I don't try to really regulate tightly their Suboxone dose. I follow them closely. I do it differently for each patient. And I also do the same as everyone else. I look for diversion of medications. I do my usual urine testing. But what I don't do is put tight limitations and impose a judgment about this medication. And also, I follow it extremely closely. I always tell patients, a monkey can write you a script and say, I'll see you in 3 months. I'd like to think I'm a physician. In that same way, anybody can write you a prescription of insulin. Now, if that insulin is going to be successful, it's unlikely that I can just write anybody a prescription of insulin and tell them, go home and manage it yourself. I'm going to have to regulate it tightly. And once they get to a position where I think everything's adjusted correctly and the clinical effect is right, they can manage it themselves. So those are two things that I do in my private practice. One, I apply harm reduction, which really individualizes care and puts the client at the center of treatment. 2, I really closely manage their medication-assisted treatment without any judgment. At the same time, manage it closely myself until I feel clinically uncomfortable that something funny is going on. If you're interested in more videos on this topic, go ahead and click the video above to my left. If you are interested in more content of this nature, please click the subscribe button and the notification bell. Have a wonderful day.